So I'd like to introduce our next speaker, Dr. Ranjan Joshi. He's a senior intensive care consultant at Women's and Children's Hospital and Memorial Private Hospital, and he's the clinical director of obstetric intensive care. He's also the chair of the transfusion committee at Women's and Children's Hospital. And thank you, Ranjan.
Thank you, Andra. Thank you, Anusha. And thanks, Anjix, for asking me to talk on this topic. What is my topic? Yeah, here we go. Well, when I looked at the topic cardiac ICU without cardiac surgeon, it didn't seem realistic to me. But thanks to Georgie now, it feels realistic. We might have robots operating on patients in future, and we not need cardiac surgeons and don't have to deal with their tempers anymore. Thanks. Good. Well, look. We are not a cardiac ICU in Women's and Children's Hospital in Adelaide. We have a pediatric ICU where we manage patients with cardiac problems. And we do have a cardiac surgeon who operates around 10 to 15 cases of PDA ligation and vascular slings. But patients who require cardiopulmonary bypass, all those patients cannot be operated here. So we have a pediatric ICU with very limited resources so far as the cardiac surgeons are concerned, and that's how, but we have to manage the patients with cardiac problems. So hopefully I will try my best to paint a realistic picture to you, and it will not be that exciting as Georgie said, and it's something you need to look forward to, but it's pretty much a realistic day-to-day challenges that you need to go through. Where are we in Adelaide? Here we are, and we don't have pediatric cardiac surgeon in Adelaide. So the nearest pediatric cardiac surgeon for us is 730 k away or 1400 k away. So that's your immediate help available. Where do the patients come to Adelaide? Well, geographically it's pretty challenging if you're in Adelaide and working in pediatric ICU, because you can see that the size of the state is pretty large. On the top of that, patients from Northern Territory as well come to Adelaide, because historically, the cardiology service is provided by Adelaide Cardiology Group to Northern Territory. So all patients, or most of the patients from Northern Territory, they do come to Adelaide. Doesn't matter what kind of problem they have, including the cardiac problem. Our ICU, we have got a 12-bedded ICU, but 7 funded bed. We've got 6 intensivists who cover 5 FT jobs. We've got 5 registrars. We've got 17 nursing staffs, where 90% of nursing staffs are critically trained. We've got 4 cardiologists, one of whom has resigned now, or retired now, so we have to fill another one. We've got 5 echocardiographers, fantastic echocardiographers. You just ask them any time to come, they will come in. We've got 1 cardiac surgeon, which I've already mentioned that. And obviously in pediatric service, as you know, the ECMO service goes along with the cardiac surgeons, so we don't have the ECMO service. But we do take patients with cardiac problems. Patients with primary cardiac problems, they come to our PICU, and if you look at around 80 to 100 patients we do admit who has got primary cardiac diagnosis. That means patients with acute decompensation for their chronic heart failure, they might have some structural heart disease, might be in the postoperative period, or patients with primary cardiac failure who comes with some metabolic problems, or patient who has not been diagnosed with structural heart disease who come in later on. All of you who work in pediatric ICU with cardiac surgical service, the most common spectrum of patients that you deal with is the congenital heart disease. And it's not surprised, because that's the most common congenital disorder that you see in newborns. In Australia and New Zealand, around 8 to 10 cases per 1,000 live births has got this congenital heart disease. So if you put that into equation, we've got around 300,000 registered births in Australia. So around 2,400 to 3,000 babies are being born every year with congenital heart disease. Where are we in South Australia? We have got around 20,000 births per year. In Northern Territory, around 4,000 births a year. So if you put that into equation, around 164 to 230 cases, new congenital heart disease cases per year are coming. So Because we don't have a cardiac surgeon, and a lot of services comes along with that, like we can't provide an ECMO service. We can't provide a simple balloon dilatation for a pulmonary stenosis, which takes probably 5 minutes for less than 4 weeks old child. Those kind of patient needs to transfer interstate. We can't provide a pacing service for a small child because we don't have a cardiac surgeons. Those kind of cases needs to fly interstate. So pretty much around we transfer 150 to 200 new cases every year to interstate from our state here. And the type of surgery are being done in our patients are not different than any other patient that are being done in other states. But what is important to notice here, that our patients who go interstate, the length of their PICU stay is, well, the normal as any other state patients will stay, that's around less than 1 week. But some of the patients can go up to 2 to 3 to 4 weeks and up to 6 months in the hospital, depending on how their post-operative period is going, depending on what the kind of surgeries are being performed. Some of the time we transfer our pregnant patient at 30 to 34 weeks, depending on the congenital heart disease the fetus has got. So the whole family has to move. But is there any advantage not having a cardiac surgeon? As I said, we don't have to deal with any tantrums of the cardiac surgeon. So we are a pretty happy bunch of people here. But there are definitely a lot of drawbacks for our children. Because we can't perform cardiac surgery, of course. We don't have the ECMO service. We can't provide ECPR, which has become a standard of care in most of the ICU service. We can't perform complex thoracic cases. We have got fantastic thoracic surgeons here, but can't operate on a tumor which is sitting on a major vessels in the thorax because they don't have the ECMO backup or bypass backup. We have got interventional cardiologists who can do interventional stuffs, but as I said, they can't dilate a pulmonary stenosis patient. Balloon dilatation they can't do, get small, and if something goes wrong, they don't have the bypass backup. I've told you about the pacing service, and the communication becomes an issue because we have got a cardiologist who will be teaching with our interstate cardiac service, but we as an intensivist will be managing the patients. Sometimes we find it difficult to communicate how severe the problem is and how urgent the patient needs to be transferred and the surgery needs to be done and to be fixed. So it's just because that there are a lot of people involved in between, and sometimes the communication becomes an issue. And obviously you can't have a transplant workup here because you don't have cardiologists, cardiac surgeons who can communicate directly with them. So sometimes we fly in our interstate colleagues here to make an attempt to tell and give an opinion or suggestion that whether this patient is eligible for the workup of the transplant or not. But what we do then? Well, we still do something. We optimize the patients preoperatively, try to work them off as far as possible before their cardiac surgery. And fortunately, most of the problems, particularly congenital heart disease, are diagnosed antenatally these days. So we have got a plan in place. In our hospital, any patients who are born with congenital heart disease are transferred to PICU for the optimization. And like this patient who had a TGA, if a septostomy needs to be done, we'll get it done in PICU, stabilize the patient, communicate with our interstate colleagues, then we'll transfer the patient after proper workup for the definitive surgery. But some of the patients, they come in without having any diagnosis, with a vascular sling and the compressing of the left main bronchus, with the air trap, impending respiratory failure. Then you diagnose the problem, get all the information possible, pass it on to the interstate colleagues, and get them transferred. No matter how we plan, all these patients sometimes might come with a postnatal diagnosis where the problem was there but was not diagnosed. Like we had this patient with 11-day-old who came with a cardiogenic shock with a lactate of 11, and we found severe LV dysfunction with increasing inotropic requirements, got intubated, ventilated, and found to have an interrupted aortic arch with severe LV dysfunction, with duct closed. We couldn't open the duct. And the nearest help is around 750 km away. So what can you do with an anatomically obstructive lesion? You try to optimize as far as possible, rush them to interstate to get the surgery done. And you can imagine how challenging it can be sometime. So no matter how much we plan and put in place, sometimes it doesn't go according to our wish. Like this child who was diagnosed with AVSD, with small aortic arch, was born by LSCS, was doing fantastic, was in step-down unit of NICU. We thought, oh, his patient is doing very well, doesn't need to be transferred to PQ even, we can get him across for definitive surgery later on. But as the day go by, patient started deteriorating, had weak femoral pulses, lower part of the body didn't look good. So we started on Prostine, got him transferred to PQ. On third day, we found that the problem got worse and worse. We kept on feeding this patient, waiting for the transfer. Sometimes logistics can be challenging. And those, as you work in a BG unit, you must be realizing how important, how difficult sometimes can be the bed pressure be. We deal with staying here 750 or 1400 away from there, waiting for a bed space. Then we noticed that this patient started having some jelly-like blood in the stool. Subsequent abdominal X-ray confirmed that the patient had developed neck now. We tried to manage him conservatively, kept on deteriorating. We intubated, ventilated, ultimately took him to theater, had end-to-end colectomy with end-to-end anastomosis. Day 4, we tried to extubate. Obviously, we failed because of the heart failure. Got reintubated, subsequently transferred, and got operated there. 2 weeks later, patient got transferred back to us, intubated, and we found that he developed fever, grew staph, found a big clot in the RA, was doing well, then ultimately had developed acute kidney injury and subsequent to a renal clot, embolic clot. So these kind of challenges we do face every day, no matter how much you have planned, no matter how much support you get from the interstate, no matter how good everything has gone by, but these kind of complications do happen. And sometimes we do encounter the post-operative challenges as well, not only the pre-operative period. Like this child who was transferred after the definitive surgery, 4 weeks after, presented to ED with respiratory failure, cardiorespiratory failure, found to have big pleural effusion, pericardial effusion. We drained both, tried to investigate why the chylothorax happened, and ultimately did all the caths, provided all the information, transferred back for another surgery. So patient who had been, where the surgery has been done, post-op complication develops, you need to transfer the whole family and the patient again back interstate, which can be challenging sometimes. But not all the patients have this problem which you can fix. Like this child who had the surgery, had a very difficult post-op course, got extubated, had extubation failure, repeated intubation, was there in the cardiology ward interstate, and developed stridor, which was undiagnosed, transferred back to us. On a weekend, presented to us with cardiorespiratory failure, tried to intubate, couldn't pass a 2.5 size tube, and ultimately the child died. And what we saw was the child had a severe subglottic stenosis where a 1 millimeter probe cannot be introduced. Forget about putting a 2.5 millimeter tube. This child presented just recently, 10-year-old kid with cardiogenic shock, brought into AD with all sorts of rhythm, with complete AV dissociation, and going into ventricular tachycardia, got intubated, ventilated, with increasing inotropic requirement, with increasing lactate. And obviously the help is, as I said, 750 or 1400 K away. We try to explore, and with all these logistic reasons, sometimes, though people are very helpful to you, but it's not possible. When you are being told that the help is coming, but it's 24 hours away, you need to take these kind of patients where the history is 2 days history of fever with acute cardiogenic shock. You might be thinking something very reversible here, but you need to take this patient through that 24-hour period, and that every hour feels like a day. And you try to optimize as much as possible with the resources and the skills that you have and take them through this. This patient was very lucky that we could take him through that 24-hour period, got the ECMO team here, transferred with ECMO, ultimately got decannulated 4 days after, apparently doing well. So that's good to know. But not everybody is lucky. Like this child who had congenital diaphragmatic hernia, who had refractory pulmonary hypertension and kept on waiting, probably any other institute you might have given the opportunity with ECMO and doing surgery later on. We couldn't, because we had to wait for the service to come to us 24 hours after, but the patient died before that. So what's the implications to us where we are providing service to our patients with cardiac problems without a cardiac surgeon? It's not only the cardiac surgeon, it's the other services which goes along with that. One is the waiting period for surgery. It's not that our interstate units don't want to operate on our patients. It's because of the logistic reasons most of the time that they have to wait some time. And obviously they need to travel. They need to travel, and it's not a short travel. It's not that from one part of the city to another part of the city. And if you're traveling, there are transport-related complications, like patient gets extubated on the way, patient tube gets blocked, or the most important thing is that we don't have the skills and the knowledge in the transport team to take a complex cardiac patient interstate. So sometimes we have to go as an intensivist from our unit, we have to spare an intensivist with the patient, then our roster becomes pretty thin on this side. And every family is not lucky to have a family support in Melbourne. And as I said, the hospital length of stay can go from weeks to months. So this family struggle with that family support, particularly in interstate. And obviously it will cause disruption to their family life. A lot of parents, they lose their income, they have strain in their family. And obviously we can't give the opportunity for the eCPR, which has become the standard of care now. There is a financial cost to it. Apart from the cardiac surgery cost, of course, there is transport. Transport is a massive cost because most of the patients who are very sick are transferred by jet. And one jet costs to our hospital around $28,000. So that's a pretty significant amount of money that goes in transport. The cost of the commercial flight, the ambulance cost, the accommodation to the families, and the heart kits do a fantastic job to provide some kind of support, but sometimes not good enough when you have to stay for weeks and months. And the hospital in the PQ length of stay, that itself is a burden and cost to the health sector. For our hospital, what's the problem that we have? Well, obviously, as I mentioned, that we do have interventional cardiologists who can do stuff but can't do because they don't have the adequate support around. Then our thoracic surgeons can't perform thoracic surgery because they don't have that support around. We struggle sometimes to attract and retain skilled people in this hospital because they don't have that high acuity of patients where they look after. Or to our training, we can't provide that adequate amount of training for the ICU training to give them that experience which can make them a better intensivist later on. We are very fortunate in that way to retain our nursing staffs, though. Most of the nursing staff has been there for years and years. And we are not the employer of choice for obvious reasons, as I mentioned. But being a supervisor of training, me myself, I always feel that our trainees are not getting the exposure they deserve or they should have. And obviously, the provision of eCPR, which I have talked about. Having said all these things, we know that the grand final doesn't happen in Adelaide, it happens somewhere else. But we play hard. We play to our best, and sometimes we win grand final too. So we are a very proud bunch of people here to try our best and give the best opportunity to our patients with the limited resources that we have. Thank you.
Thank you, Ranjan. Just wondering if anyone has some questions.
That's all right. Ranjan, that was an excellent talk.
Thank you.
If all the stars aligned and you did have the funding, where do you see yourself 10 years from now?
I told you what George is saying. Look, my personal opinion, the complexity of the patients are increasing, right? There are no more straightforward cases. 85% of the neonates who are having congenital heart surgery are making it to adulthood. You just roam around Adelaide, you'll find 5 pontons roaming around, and they come with bronchiolitis. I see, with my adult practice, patients with congenital heart disease, particularly with females, they have got all this surgery happening. No matter how much you tell them not to be pregnant, they will be pregnant. They decompensate, they come. So the complexity of the patients are increasing, not only in the neonatal world, in the adult world as well. So the congenital service has traced from the neonatal to the adult service. And this transport and transport-related complications, which is affecting the families and so much, is this sustainable? It's not. It is not sustainable. Obviously, as in Melbourne, you have got everyday population increasing by 400. We don't have that in Adelaide, fortunately, so far. If it starts happening here, then it's not sustainable. So 10 years down the line, what I would like to see, what I told that should not happen.
Thanks, Ranjan. What do you think the role is for a local ECLS program for pediatrics then to bridge that gap?
Okay, that's a very good question, Sila. Look, the good thing that has happened in ECLS program is the technology has advanced. And probably the 10 years before, when I was doing my register training with you, the kind of technology we were using, and if I look at the technology now, is very different, very user-friendly. The cannulation technology is improving. A lot of centers are moving towards cannulation by the intensivist and all. So those are all very promising signs for us, for a center like here. Well, I'm not focusing on what we don't have. What we have around is obviously some of the cardiac surgeons who has got pediatric skills, and we're not able to tap into those skills yet. If you put those things in place with advanced technology where intensivists will take a bit of more ownership, I think it's doable, and that's what we are exploring at this moment.
Thank you, Ranjan.
Thank you.